Hello and welcome to our latest presentation on COVID-19 update. This is based on the literature that has been published in the last 6 months. The coronavirus, they are large, enveloped, single-stranded RNA viruses and they cause infection mainly in animals. SARS-CoV-2 has a diameter of 60 nanometers to 140 nanometers and it has distinctive spikes which range from 9 to 12 nanometers, giving the virions the appearance of a solar corona. Bats are thought to be the reservoirs, while the intermediate host is thought to be the pangolin. Now, the host defends against the viral invasion. The virus attaches itself to the ACE2 receptor through the S protein. The TMPRSS2 activates the viral S protein and cleaves the ACE2 receptor to facilitate the viral binding to the host cell membrane. So the presence of both ACE2 receptor and TMPRSS2 is very important for a cell to get infected. Since this combination is predominantly present in the respiratory cells, no doubt the SARS-CoV-2 infects primarily the respiratory system. So the virus enters the host cells via endocytosis, releasing its RNA and using the cell machinery to replicate itself and make more virions. An infected cell can create hundreds of new virions, rapidly progressing the infection. In the early stages of the infection, the most common cells that are affected are the bronchial epithelial cells, that is the type 1 and type 2 alveolar pneumocytes. Apart from this, the capillary endothelial cells are also infected. All these things results in an inflammatory response resulting in the migration of macrophages, neutrophils, monocytes and T lymphocytes. These secrete the cytokines forming this inflammatory response. If the virus is not cleared and there is a continued inflammatory response, there is result of more influx of monocytes and neutrophils resulting in a pulmonary edema. There is hyaline membrane formation, thickening of the interstitium, and by activation of the coagulation, there is microthrombi in the pulmonary circulation. The ACE2 receptor is very important. So, the increase in the ACE2 receptor in patients who are on ACE inhibitors or ARBs has been postulated as something which may increase the mortality in COVID 19. But this study, which was published from Denmark, almost 4,500 patients, they showed there is no correlation between ACE2 receptor or ARB use with mortality in SARS-CoV-2 infections. So patients who are on these drugs can continue to take these drugs without any added risk. Now coming to the transmission of the infection. It has been proven that droplets are the most important ones and they which are released during talking, coughing or sneezing are the main method by which the virus actually causes the infection. Prolonged exposure to an infected patient that is within 6 feet for at least 15 minutes or even a briefer exposure in patients who are predominantly symptomatic like coughing or sneezing, it is associated with a high risk of transmission of the infection. The existence of aerosol in the physiological state or the detection of nucleic acid in the air does not actually mean that this particular virus is airborne or the virus that is airborne is infectious. But for all practical purposes, anyone who is dealing with a lot of aerosol formation, like people who are intubating or doing bronchoscopy, it is better to take aerosol precaution. But aerosol precaution is not required in other cases. Maternal COVID 19 is currently believed to be associated with very low risk of vertical transmission, and there is also minimal risk in lactating mothers who are breastfeeding their infants. The clinical significance of the transmission of SARS-CoV-2 from inanimate objects, that is fomites, is difficult to interpret. This is predominantly because we still don't know what is the inoculum needed to cause an infection, especially from these surfaces. And the viruses which are present on these surfaces, they decay very rapidly in the first 48 to 72 hours. But for all practical purpose, again, people who are working in setup with very high load of infection are advised to take precaution against fomite based transmission, that is by use of PPEs and gloves. The viral load in the upper respiratory tract appears to peak around the time of symptom onset, and the viral shedding begins approximately 2 to 3 days prior to the onset of symptom. 2 to 3 days prior to the onset of symptoms. That is main reason why there is such a rampant transmission of this virus throughout the world, because most of the patient before they are symptomatic would have already transmitted the infection to non-suspecting people, and this is the main reason why wearing a mask is being recommended as a method to cut the rapid spread of this particular infection. Although viral nucleic acid can be detected in the throat swab for up to 6 weeks after the onset of illness, several studies have shown that the viral cultures are generally negative after day 8. So, patients who are asymptomatic can be discharged without any tests from day 10. Now, let's see what are the clinical presentations which you have seen till now. The mean incubation period has been around 5 days. That is the time of exposure to the onset of symptoms. And up to 98% of the patients will develop sub-symptoms by day 12 of their infection. The median interquartile range for symptoms onset to the hospital admission is roughly 1 week. The median age of hospitalization is around 47 to 73 years, and there is a 60% male preponderance. Among patients who are hospitalized with COVID 19, nearly 80% are aged more than 50 years. So, male and age more than 50 years are major risk factors for getting admitted to a hospital. 81% of the patients usually have mild symptoms, 14 have severe manifestations, and 5 require ICU backup. The most common symptoms in hospitalized patients are 90% of the patients have fever, 60 to 80% have dry cough, 50 to 80% have shortness of breath, 40% have fatigue, nausea, vomiting, or GI symptoms are there in 20 to 40%. Myalgia is seen in 15 to 44%. Let's see how it affects children. Only 2 to 5% of the individuals with lab confirmed COVID 19 are aged less than 18 years, with a median age of 11 years. A rare multisystemic inflammatory syndrome similar to Kawasaki disease has recently been described in children in Europe and North America. Even this multisystemic inflammation is extremely rare, with an incidence rate of only 2 in 100,000 patients with age less than 21 years. So the disease affecting the children is very mild, and rarely the children are getting infected. How to assess and diagnose the disease? RT-PCR of SARS-CoV-2 RNA detection in respiratory samples, that mainly from the nasopharynx, is the standard of diagnosis. But lower respiratory samples are more sensitive than upper respiratory samples. Bronchoalveolar lavage has a sensitivity of 93%, sputum has 72, nasopharyngeal swabs 63, and pharyngeal swabs 32. Since these tests have low sensitivity, several serological tests can also aid in the diagnosis, and these tests can also help in measuring the response to novel vaccines. IgM antibodies are detected within 5 days of infection, with higher levels being seen 2 to 3 weeks of infection. IgG are usually seen after 14 days of symptom onset. Lab findings. Most of the lab findings in COVID 19 are non specific. So, there is no specific lab finding which we can say is very specific for COVID 19 infection. Imaging, mostly chest imaging. The characteristic chest CT abnormality for COVID 19 are diffuse peripheral ground glass opacities, but in early cases, approximately 15% of the patients and up to 40% of the cases in case of chest x-ray may have a normal finding. Finally, coming to the treatment part, there has been a lot of research, but till now we don't have anything specific to say over here. As far as the lung condition is concerned, it is best advised to follow the standard practice for management of ARDS, withholding the antibiotics until and unless we really have a suspicion of superinfection with the bacteria. And specific treatments are still experimental. The ones which are commonly used are antivirals, remdesivir, antibodies, convalescent plasma, hyperimmune immunoglobulins, anti-inflammatory agents like dexamethasone, statins, targeted immunomodulatory therapies like tocilizumab, anakinra, anticoagulants like heparin, low molecular weight heparin, and antifibrotics like tyrosine kinase inhibitors. In the next presentation, we'll be discussing the extrapulmonary manifestations, pathophysiology, and management in COVID-19. Thank you for your patience. Check our website for further info.